Dear audience, I give you a welcome to this today's webinar. And today's webinar will be given by Professor Dario Roccotello, who is a professor of nephrology at the University of Turin, has a long-standing career in rare kidney diseases, and he is the director of the University Center of Excellence for Rare Nephrology and Rheumatology Diseases. And Dario has a special unit because he combines rheumatology and nephrology, which is a very good asset in the treatment of patients with rare diseases and systemic diseases such as lupus and vasculitis. And today's topic will be the KDIGO guideline on immune glomulopathies and specifically lupus, nephritis, and vasculitis. Dario, very happy to have you, and for you the floor.
Very pleased, Jack. Thanks for your presentation. We will start with lupus nephritis, and this slide shows the suggested algorithm from initial suspicion of lupus and the final diagnosis through currently available biochemical testing. Proteinuria level higher than 0.5 gram for 24 hours of collection has been considered by KDIGO guidelines a cutoff value for proceeding to renal biopsy. And the kidney biopsies confirms the diagnosis, assess the activity, I mean endocapillary hypercellularity, neutrophil karyorrhexis, fibrinode necrosis, etc. And chronicity features like total glomerulosclerosis, fibroscrescence, etc. Biopsy also informs treatment decision, and the electron microscopy ascertains the extent of podocyte injury and the sites of deposition of immune reactants. Before focusing on treatment, let's give a look on criteria for assessing treatment response. Criteria usually used in clinical trials require improvement of proteinuria and stabilization of or improvement, of course, of renal function. Optimal reduction of proteinuria is up to 0.5 gram. Long-term data from some large trials suggest that achieving proteinuria level of 0.7 predicts a favorable outcome as well. Another controversial point is appropriate time to be assessed for the definition of response. Usually in clinical trials it's 6 to 12 months, but proteinuria and GFR can improve continuously over time. Waiting 18 to 24 months has been considered reasonable by the work group, by the group working on KDIGO guidelines. No mention on serology. Despite resolution of proteinuria, several patients have positive anti-DS DNA and low complement levels. Benefits for antimalarials include lower flare, also for kidney, systemic activity control, and pregnancy protection. So, the first question is, do you consider mycophenolate mofetil and cyclophosphamide to be similarly effective?
Okay, all listeners can now answer the question. It's a simple question, we had yes or no, so I suggest we have only a few seconds to answer this question. Okay, Dario, can you see the answers?
I can't see the answers, but yes.
No. So 62% consider them similarly effective, and 38% think there is a difference in efficacy.
In the efficacy. So we will come back on this point in a few minutes. But before, do you have any preference for cyclophosphamide? Sorry. For cyclophosphamide dosing regimen in induction treatment, that is the initial treatment of lupus nephritis.
Okay, so you can answer again. The question is whether you have preference for cyclophosphamide dosing, like either the high dose NIH schedule, the low dose LUPUS, 6 times 0.5 grams, or oral cyclophosphamide in a dose of 1.5 milligrams per kilogram per day for 2 to 6 months. Okay, I think we can close.
I can't see the answers.
No, I will give. So 23% of the listeners use or have a preference for the NIH schedule, 66% for the EuroLupus schedule, and 11% have preference for the oral cyclophosphamide.
Okay. So assume that similarly efficacy. Opposite to NIH and oral cyclophosphamide, Euroshim was mainly evaluated in North Europeans, and ethnicity in this case matters. Patient adherence is better assured by an intravenous regimen. Low-dose EuroLupus shows the best safety profile, while oral cyclophosphamide implies administration of the greatest doses that increase frequency of ovarian failure with more than 10 grams square meter for pediatric and 15 to 12 to 20 grams for adults, and also malignancy, more than 36 grams. This algorithm refers to proliferative glomerulonephritis in lupus, in systemic lupus erythematosus. That means class 3 and 4, the classification pathologists and nephrologists. Prednisone is preceded by methylprednisolone on pulses. 4 regimens are indicated by the guidelines. The calcineurin inhibitor-based regimen is a combination of tacrolimus 4 milligram and low-dose mycophenolate 1 gram. This so-called triple therapy has showed comparable efficacy to cyclophosphamide NIH scheme, but in Asians. It can be given to patients who cannot tolerate standard dose of mycophenolate. Voclosporin has been suggested as an alternative to tacrolimus in patients with more than 45 milliliters per minute of GFR, but it is extremely expensive. The mycophenolate-based is the favorite by the working group of the guidelines of KDIGO. Equally effective has cyclophosphamide. It has similar prevalence but different profile of adverse effects. It has higher medication cost but lower facility costs and a superior quality of life. It is preferred in patients at high risk infertility and in Hispanic or African ancestry. The cyclophosphamide-based regimen included the 3 options we have already discussed. The so-called B lymphocytes targeting therapy is actually an add-on therapy. We have no randomized controlled trial on agent-to-agent treatment on biologic drugs. This the use of belimumab, that is the only biologic drug up to now accepted, is based on this study. It's a phase 3 multinational randomized trial conducted on more than 100 sites in many countries. Patients with active lupus nephritis were randomized to receive intravenous belimumab or placebo, but in addition to standard therapy. At week 104, significant more patients in the belimumab group had a primary efficacy renal response, that means 43% versus 32% of placebo. Primary efficacy renal response was a ratio of urinary protein to creatinine of more than 0.7 and the GFR that was no worse than 20% below the baseline value. These results were not impressive at all, to be honest, but yet significant. The working group emphasized the need to reduce the dose of steroids. And here we have some examples of glucocorticoid regimens, dosing and tapering. A so-called standard scheme, a moderate dose scheme, and reduced dose scheme, but these schemes use glucocorticosteroids at the very lowest dose, and as compared to previously guideline lines of 10 years ago. And also the pulses dose are very reduced. So the other question is, what's your favorite maintenance regimen in lupus nephritis? Mycophenolate, mofetil, cyclophosphamide, cyclosporin, or prolonged glucocorticosteroid treatment?
Okay, everyone can answer the favorite maintenance regimen: MMF, cyclophosphamide, cyclosporin, or prolonged glucocorticoid use. Please provide your answer. Give you a few seconds. Okay, and 83% were favored mycophenolate mofetil, 5% cyclophosphamide, 2% cyclosporin, and 10% glucocorticoids.
Yes, you're perfectly online with the indication of the working group of KDIGO guidelines. Mycophenolates decrease the risk of relapse more than azathioprine and has a comparable efficacy to cyclophosphamide with better safety profile. In intolerant patients, calcineurin inhibitors can be given, but the target ranges are unknown for glomerular diseases and have been based on transplant literature. Azathioprine is less expensive than mycophenolate and usable in pregnancy. The same is for calcineurin inhibitors, but besides this condition, the working group stated mycophenolate is far the preferred drug. Data for other regimens are limited or ethnicity restricted. So the other question is, how long immunosuppressive maintenance therapy should be continued in lupus nephritis?
Okay, please give you a vote. So what is the duration of immunosuppressive maintenance therapy? More than 36 months, indefinitely, or until the kidney biopsy shows the absence of inflammation? Please select your choice. Okay, so 67% choose more than 36 months, 14% indefinitely, and 19% use the biopsy to provide the duration of immunosuppressive maintenance therapy.
These answers reflect the complexity of the problem. The total duration of the initial immunosuppression plus maintenance immunosuppression for proliferative lupus nephritis should not less than 36 months according to the KDIGO guidelines. Despite prolonged immunosuppression and more than 12 months of with more than a year of sustained renal response, a third of patients continue to show persistent histologic activity. This is why a prolonged immunosuppression is indicated as maintenance therapy. Patients who achieved only partial remission tend to be left on maintenance immunosuppression indefinitely. Mycophenolate decreases the risk of relapse more than azathioprine, and there's a What about the treatment of class 1 and class 2 lupus nephritis? Usually, class 1 and class 2 lupus nephritis doesn't need a special immunosuppression approach. And only if a nephrotic syndrome is present, that is almost an exceptional option. A podocytopathy could be supposed, and the treatment is usually limited to corticosteroids. With the only exception of patients, with the exception of patients with relapsing course that could need the combination of immunosuppressive drugs like mycophenolate first, and as a second line therapy, cyclophosphamide and rituximab. What about lupus nephritis class 5? In these cases, we have only data derived from pooled. We have pooled data or very few randomized controlled trials with very small number of patients involved. So the data that we have should be used cautiously. Usually, the class 5 lupus nephritis can be managed with mycophenolate plus corticosteroids using calcineurin inhibitors and rituximab as a second line therapy. We need to treat this patient and to resolve proteinuria because of the complications that are linked, that are bound with, associated with a prolonged persistent proteinuria. A special sample or special group of patients can present with thrombotic microangiopathy. And the treatment here is the same as the underlying disease that imply the use of plasma exchange, rituximab, and caplacizumab for thrombotic purpura. And in the case of atypic US or complement-dependent microangiopathy, the use of eculizumab, very few cases reported till now. And in the case of APS, of antiphospholipid syndrome, we have some data, not controlled, but with some but robust as well, that imply the use of warfarin continuously, not DOAC, but warfarin. DOAC have not enough evidence. Sometimes plasma exchange and rituximab can be also indicated. What about the management of patients who shows a satisfactory response to initial therapy for active lupus nephritis? That means so-called refractory patients. The working group emphasized the need to verify adherence to treatment. This implies that the use of intravenous drugs can be useful in patients who are expected to not be compliant with the treatment. Repeat biopsy can be envisaged for verify the presence of still active disease. And remember that biopsy can be much less harmful compared to immunosuppressive regimen given without enough data. And generally, it's considered to be useful to switch from to an alternative first-line regimen if you have used the mycophenolate. It's better using cyclophosphamide and vice versa. But this is the field where an extensive use of biologic drugs like rituximab has been applied. Why rituximab that is so used, very diffusely used in the real life, has not the dignity of a place in a condition different from refractory lupus nephritis. It depends on this study, the LUNAR trial, that was a randomized double-blind placebo-controlled trial, and where rituximab was added, as we showed for belimumab, to a standard therapy with mycophenolate plus corticosteroids. And the problem of this study was that rituximab was added to a standard of care, a very accepted and commonly used therapy. If in the hands of Mayo Clinic that participates in this trial, patients who were given standard therapy has a wonderful response, exactly as the only patient that was randomized to receive rituximab as an added therapy. So the background therapy, but also the number of centers involved, a lot of centers for a relatively small number of selection of non-refractory patients, which represented the better field of using rituximab. And the type of clinical outcome instruments you have, in the short follow-up, 52 weeks versus 104 weeks of the belimumab study, are main reasons for the failure of this study. But also duration of B-cell depletion and the extent of B-cell depletion must be taken into account. In a post hoc analysis of this study, it was emphasized that achievement of complete peripheral depletion, that means B-cell CD19 B cells of 0, not 1 or 2, 0, as well as a duration of complete peripheral depletion more than 70 days, were associated with complete response at week 78. That was not considered during the study. Taking into account this lesson, obinutuzumab was used instead of rituximab with a similar design. Obinutuzumab is known to have a greater antibody-dependent cytotoxicity and a more direct B-cell kill. 1 gram was given on day 1 at weeks 2, 24, and 26, the same design of rituximab, added to a standard therapy. And of course, when examining the results at 104 weeks, obinutuzumab added to a standard therapy was better than placebo. We tried to examine, but this is outside the guidelines, of course, an agent-to-agent regimen using a combination of rituximab and cyclophosphamide to treat the patient with class 3, class 4 lupus nephritis, compared to a standard treatment of cyclophosphamide according to the Eurolupus scheme or mycophenolate at 3 grams a day. Note that this regimen can obtain exactly what was expected, a complete depletion of the B cells, that means, I repeat, 0 at 3 months. And this group were well matched, 30 patients for the study group and 20 to 10 patients for the controls. And the results were comparable, but the efficacy on the long term that was comparable was also strengthened by the fact that this treatment was not followed by any other immunosuppressive maintenance therapy. So it was a strong induction treatment without maintenance immunosuppression, and obtain 70% of complete remission for long duration in these patients. Associated vasculitis. In the diagnostic strategy in rapidly progressive glomerulonephritis was emphasized in the KDIGO guidelines. After suspicion based on clinical data, urinary sediment must be carefully examined, and if rapidly progressive glomerulonephritis, serology, including ANCA antibodies and anti-GBM antibodies must be performed. you show here that microscopic polyangiitis, granulomatosis with polyangiitis, and the eosinophilic granulomatosis with polyangiitis are systemic disease with multi-organ involvement and a prevalency of organ involved that are quite similar in the three diseases. But focusing on micropolyangiitis and the granulomatosis with polyangiitis, granulomatosis with polyangiitis. Do you think that is the same disease?
Okay, so you can answer yes or no if you consider MPO or PA3 associated vasculitis as a similar disease. Okay, so 10% do consider it as the same disease and 90% answered no.
Okay. Let me emphasize that epidemiology, demographic, phenotype of disease, and the relapsing rate of PR3 associated ANCA-vasculitis and granulomatous phenotype vasculitis make this disease quite different. Also by a point of view of clinicians. If the patient is suspected to have vasculitis, it should undergo a biopsy, a renal biopsy, and sometimes it can be difficult to perform a biopsy before starting treatment. But the recommendation is to biopsy patient as soon as is possible. There are four main classes: sclerotic, focal, crescentic, mixed classes, mixed of sclerotic and focal injuries, and the outcomes are quite different according to the histology classification. So what we can find in histology matters a lot. 2 words about the definition of disease activity and remission or relapse. Remission is defined as the absence or manifestation of vasculitis and glomerulonephritis, according to the glomerular filtration rate and the urinary abnormalities. Disease activity represented the totality of signs and symptoms attributable to active disease and involvement organ. Relapse is defined as occurrence of increased disease activity after a period of partial or complete remission. Note that we have not mentioned of serology, of ANCA, for instance. Treatment-resistant disease is defined as the persistence of the disease over time and the inability to control patient with initial induction therapy. Question 6 is, in induction phase, do you have any preference for intravenous cyclophosphamide, oral cyclophosphamide, rituximab?
Okay, so please cast your vote. What do you prefer as induction therapy, cyclophosphamide according to the NIH schedule, oral cyclophosphamide, or rituximab? Okay, interesting. Here's 56% cyclophosphamide according to the NIH schedule, 7% oral cyclophosphamide, and 37% rituximab.
Okay, the role of rituximab this disease based on 2 randomized trials that proved its effectiveness compared to cyclophosphamide in the induction treatment. Some 200 patients with either relapsing or newly diagnosed associated vasculitis were enrolled in the RAID study, and the rituximab was given with the lymphoma protocol without maintenance treatment after for 18 months. The control arms received an induction daily therapy of cyclophosphamide given orally, and followed by azathioprine as maintenance treatment, and the rituximab was revealed to be similarly effective in cyclophosphamide in induction, but better than cyclophosphamide in relapsing patients. The limit of the rituximab, the RAID study, was that the typology of a patient treated with a serum creatinine less than 4 mg/dL, while the rituximab trial focuses on patients with GFR less than 20 milliliters. And the scheme used rituximab plus 2 intravenous cyclophosphamide pulses, plus of course methylprednisolone and prednisone, has been shown to be similarly effective than cyclophosphamide given intravenously according to the NIH scheme, and followed by azathioprine. At 24 months, relapses occurred in about 20% of patients in both groups. So the recommended treatment regimen for ANCA-associated vasculitis include cyclophosphamide plus steroids given both orally or intravenously. Rituximab has a option similarly effective. The working group consider mycophenolate for non-organ threatening involvement, while plasma exchange has been considered despite the results of PEXIVA study in vital organ life-threatening diseases with serum creatinine more than 5.7 milligram. That was the parameter used by rituximab scheme, the rituximab trial. Factors that can be taken into consideration when choosing between rituximab and cyclophosphamide include the type of patient: children, adolescents, frail, older adults, need to spare rituximab, relapsing disease, and PR3 ANCA disease. These are the main indication for rituximab when using cyclophosphamide. Essentially, when rituximab is difficult to be used because of difficult access, or if the glomerulonephritis is particularly severe, because the RAID study based on patients with a serum creatinine less than 4 milligram. But if you combine rituximab with cyclophosphamide, also this sample of patients can be covered. Consideration according about the route of administration include the possibility to limit the total dose of cyclophosphamide, and with and the adherence and to be sure to assure adherence of patient by using intravenous cyclophosphamide, while costs can be important for oral cyclophosphamide. The working group underlined the need to reduce the doses of corticosteroids in patients with vasculitis, based on a collateral result of the PEXIVAT trial that showed that was a non-inferiority of reduced dose of glucocorticosteroids compared to standard dose in severe in these patients. And the kind of prednisone tapering is described in this slide. What about plasma exchange that can be considered in vital organ involvement and in severe glomerulonephritis? Plasma exchange, according to the PEXIVAS trial, plasma exchange did not result in a lower incidence of end-stage kidney disease or death. But PEXIVAS included patients with with less than 50 milliliter per minute of GFR. That is a wide field of possibilities. Evidence for pulmonary hemorrhage was found only in 1/3 of cases. And hemodialysis dependent patients were only 1/5 of the entire population. And the inclusion of a substantial proportion of patients with mild disease might have obscured the detection of benefits from for the most critical outcomes. Kidney biopsy was not required for entry, but patients with advanced fibrosis would not be expected to improve with any treatment, including, of course, plasma exchange. And the study also lacked of stratification aimed at identifying the cases with extremely severe renal function. And failed to give data on subgroup analysis that could emphasize some possible benefit of plasma exchange. So, in ANCA vasculitis with severe kidney disease, in vasculitis with diffuse pulmonary hemorrhage, and in vasculitis associated with anti-GBM antibody, plasma exchange must be considered despite the results of PEXIVAS trial. Factors that increase relapse risk include in this disease include some Vasselin factors, including the PL3-ANCA subgroup and low serum creatinine at Vasselin, and history of relapse after diagnosis, and some treatment factors include lower cyclophosphamide exposure. So, question 7 is, what's your favorite maintenance regimen in ANCA vasculitis? Azathioprine fixed, rituximab on demand. That means given when the patient show some increase, some repopulation of BCD19 cells with ANCA increase, or mycophenolate mofetil.
Okay, so you can choose between these 4 different options. Okay, so this is quite variation. 15% of the patient choose of the attendants choose azathioprine, 19% fixed rituximab, 31% rituximab on demand, and 35% mycophenolate mofetil.
Okay, the use of mycophenolate mofetil is for maintenance therapy is very controversial, but the improved study showed that it revealed to be inferior to azathioprine. This is quite surprising, but anyway. The introduction of rituximab for maintenance treatment based on these trials that shows that rituximab was equally more effective than azathioprine in the medium period, the medium term, that means 18 months, that given on demand and in fixed dose was similarly effective, but less rituximab was used on the on-demand scheme, and an extended follow-up of additional 18 months of rituximab, that means 36 months, can be useful for maintain remission. Consideration for using rituximab or azathioprine based on this observation: relapsing disease, PR3-ANCA disease, glucocorticoid-sparing need can take advantage of rituximab. Azathioprine when can be preferred in patients with hepatitis B exposure or limited, and mainly in limited availability of rituximab. Question, the last question is how long immunosuppressive maintenance therapy should be continued? 18 months, 36, 48, or until kidney biopsy shows the absence of inflammation.
Okay, so you can choose between, okay, here in this poll, we are missing one option, the 36 months.
36 months.
Yeah, so it's not an item in the poll now. So okay, I think we can close. Because yeah, so 38% choose 18, 59 48, and 3% choose the biopsy. But note the 36 months option was not available in the poll.
Okay. The suggested duration of treatment is for rituximab at least 18 months, but according to Maryson trial 3, also 36 months. Azathioprine for at least 2-3 years, but there is a trial showing that 4 years may be furtherly useful for maintain treatment in this patient, and the mycophenolate for at least 2 years. But show this slide. If you consider microscopic polyangiitis and GPA, granulomatosis with polyangiitis, in the RAVE study, that where after rituximab no further immunosuppressive treatment was given, you can appreciate an important difference. And if relapse is not so frequent as can happen and occur in and happen in microscopic polyangiitis, you can also adopt a strategy of watch and see. because some patients, after an effective treatment of microscopic polyangiitis, can have a long-lasting remission without any immunosuppressive maintenance therapy. This is not clearly obvious on the guidelines, but in the text can be extrapolated quite well. So just one word about a drug that we will face in a few months in some countries and few years in other countries. The oral avacopan, that is an inhibitor of the receptor of C5a, and was found to be able to substitute completely corticosteroids, and was not inferior but superior, not inferior at week 26, but superior to steroids in sustained remission at week 22. So what can be the role of this drug that is expected to be very, very expensive? But apart from that, diabetes, glaucoma, risk of fractures, ANCA-negative patients, low basal level of complement that are possibly associated with severe renal involvement, can be putative indication for this new drug. And what is the next future? There are a lot of future options. Let me just emphasize that this trial, the endurance trial, where rituximab plus cyclophosphamide low dose will be is examined for its effect on very severe patients with ANCA-associated vasculitis, because the patients having less than 15 milliliter of GFR are not completely examined for a definite indication of treatment. This is at least in my mind. Thank you for your attention. Jack, just remember the next webinars. Genetics of human. Yeah, you can.
Yeah, thank you. Oh, sorry, go back. Yes. So thank you, Daria, for this presentation. And indeed, it's good to show the next webinars and invite people to listen to them and register for them. We have a few time to have some questions, and there are many more questions than we can answer right now, but I will try to summarize. And one issue is that let's say the standard therapy in membranous in lupus nephritis with either urolupus or MMF induction therapy, I think I would say still the majority of patients respond to induction therapy. So the question is, when do you use additional treatment with, for instance, belimumab in these patients? Do you think it's better to start with all multi-targeted treatment at once, or is it better to do a sequential therapy and only select the patients who have not responded within 3 to 6 months to the standard induction therapy and then add, for instance, belimumab?
The role of belimumab, I think, is still under examination, must to remain under examination. Why? Because belimumab showed some benefits when added to a very strong therapy that we know that can obtain good results. Belimumab is not is expensive, an expensive drug, and of course can assure some more effect effectiveness in the more severe patients. So I don't think we can envisage the use of belimumab added to standard therapy as a first-line treatment. But maybe when histology is particularly severe, and about the combination therapy with the triple therapy, even though there are some data that seem to prove some effectiveness of the combination of calcineurin with inhibitors with mycophenolate low doses, also in Caucasians, the majority of data were collected in Asian populations. So I don't think it's time to change our behavior in the treatment of this patient, at least in Europe.
Okay. So do you think that at the moment there is a real advantage of voclosporin over the traditional calcineurin inhibitors?
Voclosporin is costs, I think, some $1,050. Well, no, sorry, $150,000 a year in USA.
Mm.
So I cannot find a clear place for voclosporin right now. Let me explain. Voclosporin was used again as an add-on therapy. So we have data on voclosporin used plus mycophenolate at standard doses. The working group of KDIGO guidelines suggested the use of voclosporin instead of tacrolimus in some patients, combined with low doses of mycophenolate. But I don't think we have data enough to be sure that voclosporin given with mycophenolate, not at the dose that were tested in the previous study, can be equally effective. Another limitation of voclosporin is the type of patient that must have at least 45 milliliters of GFR. And so the very severe patient cannot be putatively treated. And so I think that we need some more evidence to start with using voclosporin, apart from the costs that I think are a problem, are a true issue.
Yeah, I totally agree. The new drugs we should wait. So one question is about, we haven't talked about COVID. So one question is, what is your experience with relapse of lupus and also relapse of vasculitis in patients who either have COVID or have been vaccinated against COVID?
What we can say is of course limited to very few cases. So I can just report our decisions in some conditions, some particular cases that we had to face in this unlucky period. A patient who were not vaccinated, and they were at high risk to be infected with COVID, were often treated with steroids and if needed, the plasma exchange, waiting for at least one dose of vaccine before given immunosuppressive drugs. Cases of true vasculitis with ANCA characteristics, with ANCA pattern after vaccine of COVID, I don't remember to have seen till now. We have a paper impressive on the American Journal of Nephrology on our experience on new onset glomerulonephritis that didn't include any cases of ANCA-associated vasculitis. We had some relapsing in our patients, but not so strong to require a repeat induction. I mean, it was managed just with an adjustment of the maintenance treatment.
Yeah, so just to specify, for you, there is no reason to warn against the use of the vaccine in patients who have lupus or vasculitis and are on maintenance therapy, or even after withdrawal the maintenance therapy.
Listen, Jack, we vaccinated some 20,000 patients with rare diseases and more than 5,000 patients with immune mediated diseases. In the past, we were very cautious with vaccine, especially with live vaccine. With COVID, we changed our behavior because we decided that we had a lot of discussion about that rheumatologists and nephrologists of our, but not only our department, and we participated also at the Italian guidelines of the Italian Society of Nephrology. What we decided was that the COVID infection could be worse than relapsing disease and any cases of new onset we collected and denounced to the institutions, but finally the true new onset and the true relapses were much less frequent than the number of patients we brought to vaccination.
Yeah. So there is no reason to withhold vaccination in our patients. Okay, it's time. I thank you very much for your presentation, Dario. It was a broad topic, and I'm sure we have learned a lot today. So thank you again for the presentation. Thank the audience for listening. And please have a look at the next webinars. The first one is on 22nd of February on the genetics of human renal agenesis and renal dysplasia. And you are welcome to attend these next webinars. I wish you all a good evening. And again, thank you very much. Bye-bye.
Bye-bye.
Bye-bye.